Before I get started on the presentation, I would like to thank the organizers for inviting me here in this very nice meeting, very nice country. And these are my disclosures. We investigated the effect of a fixed duration therapy of venetoclax in combination with obinutuzumab in previously untreated patients with CLL with coexisting conditions. That is called CLL14, following the systematic approach of the German CLL study group here. And I will be talking about these topics really with particular emphasis on data on efficacy, including data on minimal residual disease. Right. By now, I think we all know that the vast majority of patients really are unfit patients, as we loosely call them. And if we look at the current standard of care, and those patients do need then less toxic regimens, it is really as simple as that. It is either chemoimmunotherapy, and we've only heard Dr. Goethe confirming this this morning, or it is, since more recently, continuous indefinite monotherapy with targeted agents. And that was the reason why we decided to develop a new regimen that is fixed duration combination therapy with targeted treatments. And the idea really was to replace chemotherapy by venetoclax, a BCL2 inhibitor that has shown excellent activity in patients with CLL. And the idea really was to combine now venetoclax with another strong compound with obinutuzumab, following a solid rationale of both clinical, but also this preclinical data suggesting a maximal additive effect for venetoclax when combined with obinutuzumab, rather than with rituximab or venetoclax alone. Now, it is of utmost importance to define a strong and appropriate comparator arm, and in this case, the predecessor trial of CL14, the CL11 trial, had previously established glombucil and obinutuzumab as one of the current standard therapies in this patient population. And we have only heard Dr. Goethe presenting the 5-year follow-up of the study, and interestingly reporting for the first time an overall survival benefit of obinutuzumab over rituximab. Now, whether or not the progression-free survival, which is median progression-free survival of 31 months, can be further improved, now this is the key question and the primary endpoint of our trial. And we designed then CL14 as a multi-center phase 3 trial where patients were centrally reviewed in order to confirm their eligibility, including their coexisting medical conditions with a CS greater than 6 on the score and or creatinine clearance below 70 milliliter per minute. And patients were then randomly assigned to receive either venetoclax obinutuzumab or glombucil obinutuzumab. No crossover was allowed, and the primary endpoint was progression-free survival. We opted for obinutuzumab first, followed by venetoclax, in order to minimize the risk of tumor lysis syndrome here. In particular, all patients received a standard equal duration treatment of 12 cycles of either glombucil standard dose or venetoclax, and either or then combined with obinutuzumab for the first 6 cycles. And these are the patient's characteristics. Of the 432 patients enrolled, 216 were randomly assigned to each treatment group, making up the intention to treat population here. And as you can see, the disease as well as the demographic characteristics were well balanced in both treatment arms. And I would like to particularly indicate that really with a median age of 72 years, a CIL score of 8 and a median estimated creatinine clearance of 66 milliliter per minute. Now, this trial population really was representative for most patients with CLL here. And the same goes for the cytogenetic data. 60% had an unmutated IGHV status, 12% had TP53 deletion and or mutation, and 8% of the patient had deletion 7TP. Now, after a median follow-up of 28 months, and in that time all patients had come off treatment for at least a year, the progression-free survival was significantly higher for venetoclax or obinutuzumab, hazard ratio 0.35. Median progression-free survival has not been reached in either group here. Accordingly, the 24 months progression-free survival was 88% for patients with venetoclax obinutuzumab, 64% in patients treated with glombucil obinutuzumab. And interestingly, this benefit in progression-free survival was also observed in all clinically relevant subgroups, as you can see here, for patients with unmutated IGHV mutation status, represented here by the black curves, indicating that venetoclax really was able to overcome the adverse risk of unmutated IGHV mutation status here. And the benefit was also seen in patients with TP53 deletion and or mutation. As you can see here, the median progression-free survival has not been reached. 24 months progression-free survival is 70% for these patients. No difference so far has been observed in overall survival between the treatment groups. Thus, the relatively short follow-up of 28 months and the limited number of events, you can read these out for yourself here, just might be too early to detect here any difference in overall survival. The more important it is now to look into the minimal residual disease here, the MRD negativity rates assessed in the intention to treat population, and here assessed by ASO-PCR were significantly in favor of venetoclax or obinutuzumab, both in peripheral blood. There was 76 versus 35%, but also in bone marrow with 57 versus 70%. And if we look at the complete observation time of the study, then really it is noted that the MRD negativity rates were consistently in favor of venetoclax or obinutuzumab. And most importantly, this finding was maintained after completion of treatment, as you can see here, whereas a rapid increase in minimal residual disease was noted then for patients treated with glaucoma or obinutuzumab, actually starting then right after completion of therapy here. And again, these data were further confirmed now by the MRD negativity rates, and this time as assessed by next-generation sequencing data here. And again, this is the intention to treat population, and it is 42% of the patients that reach an actual MRD negativity level below 10 to the minus 6 here. Of course, it would be interesting to see how these deep responses, or if these deep responses might eventually translate then into an improved overall survival. Now I would like to conclude. We showed that fixed duration venetoclax in combination with obinutuzumab can be safely administered, and I do apologize for actually not having shown any of these data, so you will have to read this out for yourself in the manuscript. This combination provides a superior outcome regarding all relevant clinical or efficacy parameters, as shown here, and most importantly, I mean, this is a 12-month treatment duration here, and hence it achieves the highest rates of MRD negative responses that have been observed in a prospective study so far. So with this, I think we have introduced a new treatment paradigm here, which makes it then two treatment paradigms that are completely different. We've got on the one hand the continuous indefinite monotherapy with ibrutinib, and now we've got on the other hand the fixed duration combination therapy. So the question really is, wouldn't it be good to compare these two? And I think it would. And I think it is this very study that, if I may say so, dares to ask all the right questions here, thanks to the study lead, Dr. Osman Al-Zawaf, who effortlessly but very determined manages all the different aspects here in order to initiate this really investigator-initiated trial together with all our collaborators. And it is actually on behalf of all these collaborators and the negotiating partners that I'm really delighted to announce that CLL17 will be starting in the middle of next year. So this is it. And this brings me actually nicely back, because it's always a humbling responsibility to conduct a clinical trial. So thank you very much for all the investigators that participated in CLL14. And of course, thank you very much to the entire CLL14 team. This is a collaborative effort between industry and academia. And I would like to thank especially Michael Halleck and Osman Al-Zawaf, Manish Tandon, and Michele Pokolura. Thank you very much for your attention.
Peter?
Thank you, Kirsten. It's a great trial. So are you comfortable with stopping therapy in the MRD positive patients, particularly the ones with high-risk features, so which is probably about half of the patients? Well, that's the big challenge for us, I think.
I mean, in the venetoclax obinutuzumab arm, there's only 19 patients so far, so we really don't have much data. And indeed, 60% of these patients are unmutated patients. So we are really trying to figure out, at what time point what happened and if we need to do some adjustments here. But so far, we don't have any specific recommendation on that and data on that.
Okay, thank you.
Thank you.